Thank you very much, Dr. Rodrigo. You can continue employment, which is very good to see. I'm talking about another cheerful topic about substance use and offending. And this is, of course, of relevance to all of us, not just as psychiatrists, but also as citizens, because anything that can reduce offending is going to improve the health and well-being of our societies. In forensic mental health, we always find the conjunction of personality disorder, substance misuse and mental illness associated with offending. And I suppose it's really difficult to unravel some of the associations, and once more I'm going to draw on the work of Sina Fazel's work at Oxford to explore some of the linkages between those. COVID has taught everyone how to be an epidemiologist, so everyone knows a bit of the language, but I want to reflect a little bit about how it is that we attribute various behaviours to particular mental conditions. Our patients often say things like, I was self-medicating with alcohol, or it was the voices that made me do it. But of course, those are very simplistic attributions, and the reality is a little more complex. So, without putting the horse before the cart, we always need to be sure that we use the correct language in talking about associations and correlations, rather than making unverifiable assumptions about the particular cause. Often that's just a retrospective attribution which seems convenient, and it often reflects, as much as anything else, our countertransference. Patients to whom you are sympathetic will often engender some sort of exculpatory explanation, something which removes blame from them, and patients to whom you have a hostile or a negative countertransference, you will often find blameworthy. So the possible relationships we see, particularly with substance use, so that the substance use can cause the mental disorder. It could cause mental disorder in those who are predisposed, and I'm reflecting on yesterday's debate about legalising cannabis, because for most people that will simply make them boring and put on weight, but for a few people it will make them crazy, and some of those people will cause serious problems. In some cases, I know the term isn't really used anymore, but people in the early stages of developing a mental disorder will use drugs due to perhaps a shared causation. And then finally, we also know that there are some mental disorders which lead to increased drug use. I'm always struck by the statistic that in Australia, which has very successfully reduced nicotine smoking rates to around 15%, that the rates in people with schizophrenia are 85%. So that, again, figure that was shown yesterday, our patients are spending a huge amount of their disposable income on tobacco due to something obviously about the brain of a person with schizophrenia which has a different response to nicotine or a different capacity to cease using it. So some of these will demonstrate that in fact substance use is a confounder, so it looks like the mental disorder but is not, or a mediator, that it's a step along the pathway of causation. So let's try and unravel some of those links. This looks like your beautiful freeways, empty of traffic, smooth driving. The first I mentioned was personality disorder, and of course in the last 20 years we focused a lot on psychopathy as a subset of antisocial personality disorder. And of course the features of psychopathy which predispose to offending tend to be the ones which overlap much more with narcissism. The antisocial behaviours aren't so relevant, but the narcissistic ones we find are strongly associated. And if we look at that association, firstly some research from the Swedish groups in the past, what this shows is that in both forensic patients and prisoners, the presence of psychopathy is a strong independent risk factor for offending and for reoffending. So this looks at the number of offences, and it shows that people with schizophrenia and substance use offend less than people who have the combination of those with psychopathy. So which substances are relevant to offending? The ones which we see predominantly in Australia at the moment are stimulants, so methamphetamine is the main association with offending. And I'm old enough to remember when that first became a factor. Our heroin usage rates declined quite significantly, and so there was a reduction in the acquisitive offending associated with that. But methamphetamine, often in conjunction with benzodiazepines such as alprazolam, both engendered aggression and amnesia, and you would have prisoners talking to you saying, I've seen the video evidence, it was definitely me that did it, but I have no recollection whatsoever, and it's right out of character for me, doctor. Some of the other sorts of drugs can be relevant to offending, but I want to focus a little on the main drugs which are perhaps relevant here. Now, if we look at this particular association with disordered mental states, obviously more pluses represents a greater association. Alcohol being the main offender for people who end up in prison with serious offending, not really associated with psychosis, but obviously associated with not so much a mental disorder, but executive dysfunction, disinhibition, impaired judgment. Cannabis, not so strongly associated with offending except when mediated through mental illness. I put in nicotine as relevant because if our patients smoke nicotine and come into prison, it's going to affect the metabolism of antipsychotic medication, and it's also going to affect the capacity to comply with medication when in the community in the future. So nicotine is of course relevant, and we always have to remind ourselves to register it as a diagnosis, that nicotine dependence is not something which is simply the norm or something which doesn't record a diagnosis. If we record it as a diagnosis, it encourages us to engage in brief interventions to address it as a disorder which is going to cause the death of most of our patients. I meant to put in at the bottom opiates, and that's because opiates of themselves don't seem to engender mental states associated with offending. They don't seem to be associated with violent offending or sexual offending. They're certainly associated with acquisitive offending to fund the substance use, and they're associated obviously with dealings in the drug world which are associated with offending. So the sort of possible mechanisms by which substance use is linked to offending are, just as I said, that it can be used to fund the substance use, that it can induce a mental state which is associated with offending, that it leads you to affiliate with other people who are using illicit substances and who consequently are likely to have antisocial personalities, but also that it estranges you from society. You end up marginalised, potentially homeless, cast out from your family, and a lot of the strong protective social factors are no longer present. Alcohol being the main particular offender, this gentleman is never successful. So thinking about the substance that you're reflecting upon, the mental states are associated with particular links to the use of substances, either intoxication or withdrawal, triggering a particular episode of mental illness, substance-induced psychosis itself, and then causing other mental disorders, including cognitive impairment due to prolonged substance use. And as I said before, the association might be straightforward, but at the end of the road, all paths lead to the same sorts of altered mental functioning, particularly affecting executive dysfunction. When I worked with sexual offenders, I always used to marvel at how it was that one episode of sexual excitement was clearly something that was so worthwhile to the offender that they would sacrifice years of liberty. And obviously that's not a rational judgment. People aren't simply weighing up the pros and cons. Will this little burst of dopamine release and an episode of sexual satisfaction, is that worth the risk of 20 years in prison and being expelled from my family? Most people wouldn't obviously make that as a rational decision. Let's look at some of the adverse outcomes then from substance-using populations who have particular mental disorders. So here we see that the odds ratios for adverse outcomes, and this includes violent offences, it can include premature death, and you can see that the odds ratio is markedly increased for schizophrenia, particularly for women. The sorts of adverse outcomes are really significant. So we're talking premature mortality from any cause, we're talking about significant violent offending. And as I said in my previous talk, the association with schizophrenia and violent offending is enormous. Much of that offending happens within the family and isn't brought to the attention of police. Much of it is also disordered offending, which was predictable perhaps by the community team looking after the person. in that they saw that they had a small cohort of people that they thought were at escalated risk, but they couldn't detain them preventively, and they couldn't pick which of those people would go on to commit a particular offence. In terms of prisoners, this is simply looking at substance use and outcomes for a group of prisoners. It's again a systematic review and meta-analysis, and it takes prisoners as the category. So the association of violence with alcohol and drug use compared to people in the community is 2 to 3-fold. Many of these seem sort of pretty straightforward. It doesn't seem to be a spectacular fact, but of course we do need the science to confirm our hypotheses and to determine indeed how we shift our policy. Do we shift our policy towards compulsory mental health treatment for more patients? Do we shift our policy towards sustained alcohol and drug treatment for patients? If you had to choose between those interventions, you'd like to base it upon the science to work out which is most likely to reduce offending rates. This was a really elegant study in a large Scandinavian cohort in which each person with schizophrenia was matched with a sibling who did not have schizophrenia. So obviously that controls for many of the influences from the family of origin, for socioeconomic status, for educational level. And compared to their non-affected siblings, you can see that the odds ratio that you're likely to have schizophrenia is significantly increased, and then it's increased even more with substance use. So substance use itself appears to be a more potent contributor to offending than schizophrenia alone. If we look at reoffending rates with substance use, so here the reoffending rate is taken with schizophrenia as the baseline, and then you look at people who, in addition to schizophrenia, or compared to the people with schizophrenia who have a different disorder, including substance use. And so what you can see here is that the substance use disorders and personality disorder appear to be the most strongly associated reoffending risk compared to schizophrenia. So if schizophrenia's baseline rate is 1, the elevated risk is significantly higher, to almost 1.5 to 2 times the rate. So what that means, of course, is that when we're looking at our cohort of people in prison with schizophrenia, the ones with the substance use problems are the ones that you really want to focus your efforts on. And you also figure that it's not simply sufficient to treat schizophrenia if you don't also treat the substance use and regard that as an ongoing treatment goal. In Australia, that's often problematic because in the 1980s, mental health and drug and alcohol services parted ways and have different oversight, different funding streams, different workforces. And as a result, you have to knock on 2 doors to get your treatment. It's really hard to knock on 1 door and find someone to get your treatment. Fortunately, I think most psychiatrists who work in forensic mental health have a strong understanding of substance use, are usually proficient in brief interventions and know how to prioritise those. But it is, I think, a core part of forensic training to have a good working knowledge of substance use. And then finally, we look at re-hospitalisation rates. So for forensic patients, using schizophrenia as the baseline, the population with substance use was much more likely to be re-hospitalised. And interestingly here, if you look at the lowest line, personality disorder was less likely to be hospitalised compared to someone with schizophrenia alone. So the substance use there remains a really strong contributor to re-hospitalisation rates. Now this next image looks a little bit busy, but I just want you to think about this as a developmental trajectory for an ordinary person. And some of those people, some of the people we went to school with, went to primary school with, grew up in the same area as, go on to develop mental disorders. As you know from your own experience, you can't predict who those will be necessarily in childhood. But going from the top, we know that there are associations with the number of adverse childhood experiences. We also know that there's overlaps with developmental disorders. It's likely that those impact upon retention in education, and it's also likely that those adverse childhood experiences as well lead to maladaptive personality traits. The combination of these is also likely to lead to other forms of psychosocial adversity, which tends to reduce the number of protective factors that I've spoken about, being maintained in your family, having stable accommodation, having employment. All of these are factors we know that reduce the likelihood of offending. As a consequence, You can see that the pathway leads you to affiliate with an antisocial peer group. And then in the population who develop mental disorder and substance use, we know that these are more difficult patients to like. They don't attend their appointments, they're rude and surly, and so that population is perhaps more likely to be rejected from services or to fail to receive effective follow-up compared to a population who are pleasant to deal with, take their medication and appear gracious. They're not fulfilling the patient's part of the deal. So again, it's incumbent upon us in forensic mental health to deal with that countertransference, to maintain our professionalism and to focus on how it is that you offer treatment to people who are sometimes unpleasant and difficult. I've talked about the need to use evidence to inform policy, and I think that's a really great opportunity you have here to drive services in the direction that you want. When we think about this pyramid of public health interventions, thinking that what we're dealing with in forensic mental health is the top. We're dealing with people who have already committed their offences and we're watching the horse running down the road, the stable door is wide open. Ideally, we want to be dealing at the second level, which is where you pick people who have the risk factors you know that are associated with future offending risk, and you're intervening preventatively. And I'll talk about some of those interventions in very straightforward terms. And then, of course, the Holy Grail, what we'd really like to be doing is dealing with it at a primary level, picking children who were at risk, picking juveniles before they were offending, and providing interventions which actually changed their trajectory away from offending. And I think most who work in child and adolescent psychiatry are very strongly motivated by that wish to perhaps alter the trajectory of significant numbers of young people and direct them into better lives. The sorts of interventions which are effective, and we're thinking here about the tertiary for people who have already committed offences. The first is obviously secure detention, and the two things that doctors always say when they work in forensic mental health is firstly that they have enough time to develop relationships with patients, to reflect upon them, to think about them. They're not simply rushing them in and out and filling out discharge paperwork and looking at the building queue in the emergency department, so that's really important. And that's also, of course, associated with protracted periods of compliance with medication. And we all see patients who don't get better in a day or a week or a month. They don't get better in a year. Sometimes it takes 3, 4, 5, 10 years of sustained medication before there's a real shift in attitudes. Now, maybe that's confounded by ageing, but in many cases we really just see that the symptom reduction takes a very long time. So long-acting injectable medications are really critical in forensic mental health, as is clozapine. At our service, we have around just over 40% of our patients are on clozapine. For a lot of people looking from outside, they say, well, it's an oral medication, how can you trust the patient to take the medication? But patients that take clozapine tend to report increased satisfaction with it compared to other medications despite its adverse effect profile. And the reason that they say that is because of the improvement in mental state, reduction in violence, reduction in distressing psychotic symptoms. I was on a ward that Dr. Rodrigo manages, and seeing a man who 2 years before the police were being called, he was naked and on the rooftop holding siege, and instead you could sit down with him and have a pleasant conversation. He could have a bit of a chuckle about his previous behaviour, and it was all due to clozapine, and perhaps Dr. Rodrigo's excellent ministrations. The other evidence, of course, is for substance use interventions. I mentioned earlier long-acting buprenorphine. So this has been a real shift. When COVID hit in New South Wales and the prisons were locked down and all visits stopped, people's sources of illicit buprenorphine, which was smuggled in by visitors, disappeared. And it coincided with the rollout of the long-acting injectable buprenorphine. Substantial numbers of prisoners who had either come into custody dependent or who had developed their drug dependence in custody switched on to the long-acting injectable buprenorphine. And that was, I think, a real shift because those people will go out into the community, their risk of death from overdose will be reduced, they will remain engaged with services in order to obtain their medication, so you have an opportunity for health promotion. And of course, you reduce all of the offending associated with seeking to obtain your opiates. It also appears to have some action in reducing craving for other substances, probably through a dopaminergic effect, but that means that for people with severe alcohol dependence, cannabis dependence, methamphetamine dependence, there appears to be it hasn't really been verified in the research literature, but certainly subjectively, some patients report a significant reduction in their craving for other substances. Other offence-specific interventions are also really critical, and there was after the British Probation Service revealed staggering data showing that there was absolutely no benefit in reduction of future offending for sex offenders undergoing sex offender treatment programs, so 250 hours of intervention. A further meta-analysis by Therese Gannon showed that there was indeed a positive effect size, but only when the group was led by a trained psychologist, not with other group leaders. So addressing other treatment targets such as substance use and personality disorder also appears worthwhile, but perhaps not as much as the others. And then finally, when a person returns to the community, the capacity for assertive community management by nursing staff who are trained in following up patients and ensuring compliance. For the secondary interventions, for those where we figure that there are targets which we could meet in a larger population, the main intervention that's really critical is that prison screening, is being able to select the population in the first place. And also, as was mentioned yesterday in the excellent talk on motivational interviewing, enrolling the patient as a collaborator in the enterprise, not in directing them, not in telling them what to do. Of course, you always have coercive frameworks, but actually making sure that you can bring them on board to join in. And then, of course, we have mandated treatments either through correctional systems or through mental health systems, which engage people in treatment and during the period of engagement appear to reduce offending risk. The final interventions are those primary health ones, the ones at the most basic level. Again, you can pick through prison screening people with other disorders which might require intervention. You can hopefully divert people from prison in the first place. But in fact, what you probably want to do is spend your money not on healthcare, but on a whole range of other issues. And if there's one fabulous publication, one of the best plain language, almost a philosophical publication. This was published by the Chief Scientist of New Zealand in 2018. It's publicly available on the internet. And it's a plea for justice reinvestment. It's saying prison is not working because people keep reoffending and coming back. We're detaining huge numbers of young people, and in New Zealand, Maori people, Indigenous people, and we don't want to be doing that. So this was actually a plea to take all of the money from prisons and instead plough it into special targeted education for children who are at risk of falling out of the education system, supporting families who aren't managing parenting well, nutrition and health advice for children, pathways to vocational employment for people who otherwise would be unemployed. All of the money that we spend on prisons, we could reinvest in these health interventions, public interventions and policy interventions which might actually reduce the need to treat offenders in prison. Thank you very much.